extra strength Vicodin? I think not. So the CDC, when they came out with their recommendations in 2016, they actually went so far to say that non-opiate therapy is preferred for chronic pain and only to be used when benefits to pain and function outweigh the risks. And function has really become kind of the key word when thinking about chronic pain treatment and opiate therapy. Really not talking so much about pain control anymore, but about improving people's function. So chronic pain treatment, we could spend an entire hour talking about this, but I'll give you my, my 3 cents about it. You may or may not be surprised about how many, I've spent about a year working at the pain clinic at UVM when we had a provider leave, and I couldn't believe how many people didn't actually have a diagnosis. They didn't have like a true diagnosis to support the use of opiates. It's so important to have a diagnosis other than just pain or non-specific body pain or non-specific back pain. Why are you using these very risky medications in this patient? I feel like we should have really good rationale for it. Documenting what non-opiate and non-pharmacologic treatments have been tried, and not giving up on these things too quickly. These things take time. And again, resetting expectations about being completely pain-free. Are they resuming some life-rewarding activities? Are they doing more at work? Are they able to do more socially? Are they able to increase their physical activity a little bit? Another important thing is to really think about addressing other chronic health conditions that contribute to chronic pain or inactivity. Right? There are lots of surgeons, orthopedic surgeons, who won't operate on smokers. This is why. Obesity, big contributor to inactivity and chronic pain, and clearly mental health disorders. And there's, diabetes and lots of other things that also contribute, but just some ones to think about. At least I was taught, if you're really going to control someone's pain, they need to be on these opiates, scheduled regularly. Use the long-acting ones. Have it on twice a day is better than, kind of intermittent short-term use. And I really think that thought is changing. Really, I don't know why we were always afraid of kind of using PRN opiates. If you can have someone on 1 or 2 Vicodin a day, it's probably much better than having them on OxyContin 40 BID. So really thinking about using these medications really just for kind of time-limited trials, and like I said, not being kind of afraid of well-controlled PRN use. When you're initiating these with someone, and I know this is probably not most of the population we're talking about, as a lot of the patients we're already treating are already on these medications. But if you're thinking about continuing it with somebody, really setting expectations up front that the opiate is going to be discontinued if decisive functional benefits are not observed, and then agreeing on what that means up front. What is the patient expecting to happen? Are they expecting they're going to go from being in bed 24 hours a day to running a marathon? It's probably not a really realistic expectation, but if they're not meeting their goals, really taking someone off the medication, off the opiate. And thinking about using these or not using them chronically in people with heart problems, lung problems, renal or hepatic dysfunction. How many of our elderly patients don't have at least one of those? Folks with sleep apnea, mental illness I've mentioned, and substance abuse disorders. Very risky population to be taking these meds. Again, avoiding concurrent benzodiazepines. I know lots of providers have said, pick one. You have your opiate, your benzo. You can't have both. Avoiding long-acting opiates and avoiding high-dose opiates. And that, I think, does mean tapering everyone that's on more than 90 MMEs down to under that level. Again, not an easy conversation to have, but really the flag should be around 50 MMEs a day. That you should really start thinking about if someone is on too high of a dose. Avoiding opiates without the abuse deterrent formulations in them, like the Vicodin ES does not have the abuse deterrent formulations. And then, again, as patients become kind of ambivalent about it, we become kind of ambivalent about it, you see patients every month and you're just refilling their opiate and you're just going along on this track, I think at some point we stop kind of reconsidering what else we could do. And so I would urge you to keep thinking about what non-opiate and non-pharmacologic treatments are out there. Could they be doing something else to better manage their pain than just take opiates? You know, and there we could do a whole other hour just on what other things you can use to treat chronic pain. But you know, there is lots of literature around antidepressants and anti-epileptics. There is some efficacy with those. Scheduled NSAIDs or scheduled acetaminophen, if they don't have other medical contraindications to that. Muscle relaxants are used quite a bit. So I think just about everyone now is doing a controlled substance treatment agreement or a contract. We actually create contracts with our patients when they're admitted to the hospital as well. Now a kind of behavior contract about patients leaving the floor and what that looks like and when they might buy themselves a urine drug screen or even dismissal from the hospital. But on the outpatient side, really tying patients into one prescriber, one pharmacy, do your prescriptions in 7-day increments so they're not landing on a weekend. Expected timelines for follow-up. I make my patients have phones. I said if I can't get hold of you for a random urine drug screen or a random pill count, that counts as a violation against your contract. And consequences for failure to comply. The other thing is really making sure that you and your patient know what the treatment plan is. And the treatment plan usually is more than just taking the opiates. So if they're not doing all the other things they're supposed to be doing, even if it's their daily walks or going to group therapy or going to massage or whatever it is else they're supposed to be doing, I would consider that a violation of their contract. The new Vermont rules require now that you have to reevaluate someone at a minimum of every 90 days. Again, doing a functional assessment. We built these right into Epic for our providers with chronic pain patients, and these are some of the tools that we have available to people because some of them address different types of things like back or neck or, you know, unfortunately there's not one really good functional assessment that you can really use for everybody. And then really, again, looking at medication dose, effectiveness, side effects, potential risk to your patient. Has anything changed with your patient that you might need to reassess their use of opiates? And I cannot stress enough that really do not overestimate your ability to detect misuse or abuse or even diversion. I have been duped more than once. I was doing one of my Suboxone clinics recently, and I saw a name on my schedule that I recognized from my community health center days, and he walked in, he didn't look familiar, and I said, oh, I thought I knew you. And he's like, I'm like, but you don't look familiar. He's like, no, but I know you. So his kid's 23. He's been clean and sober for several years now. He'd been in jail for years, lost custody of his kids, lost job, lost housing, lost everything. But now he's, you know, he had been doing great. I was just getting him out of the Howard Center for buprenorphine. He's like, but I know you. He's like, you prescribed opiates to my dad at the community health center who had the same name. And his dad had throat cancer, so I thought, you know, assumed he had pain. He told me he had pain, but it turned out he was selling all his opiates and brought his then 13-year-old kid into the family business of selling opiates and taking opiates. And so this guy that I'm seeing now had a 10-year history of opiate addiction to meds I was prescribing to his dad. I was like, oh my God, like, you know, and I've tried to remain pretty vigilant about this. And so you really have to treat everybody the same. You have to, whether they're elderly, I mean, I can't tell you how many people take pills from their elderly grandparents. You really have to apply these rules across the board. And then when people say, well, you're just treating me like an addict, you can honestly say, no, I do this with all of my patients on these medications because they are that risky. You know, and I would also encourage you to think about including benzodiazepines and stimulants in your thoughts around these kind of screening. Co-prescribing naloxone, and then again, if benefits are limited or not sustained over time, taper off opiate therapy. And what to do about legacy patients? That's a tough one. I know in our primary care practices at UVM, we have lots of patients on way more than 90 MMEs a day. Patients at the pain clinics are on hundreds of milligrams of MMEs a day. And I think that you've got to have an honest conversation about with these folks, that this is not, that we're not able to continue this. Because I really think it puts the patient, the prescriber, and the organizations at risk. So I already mentioned increasing your level of caution in patients over 50 MMEs a day. Same prescribing rules apply. No long-acting, no benzos, no high dose, no non-abuse deterrent formulations. Really looking at functional assessments. If people are still home, not working, not doing anything all day, why are they on opiates? You know, I can't tell you how many, it's ADHD meds is another one. I see a lot of people on ADHD meds that are really not improving their function. You can safely taper by about 10% a week until you reach a reasonable dose. This may take you months, and if you do it slowly, generally people aren't going to notice any kind of physical effects or any withdrawal. And I got a question from one of your medical staff: should we just taper everyone on chronic opiates for non-cancer pain? That's a great question, and I can't say I have the answer to that. I think it's, again, about the risks and benefits of the medications to each patient, but it's worth thinking about. The conversation is, again, I know you've been on these medications for years without any issues, but we have new evidence that they put you at risk.
When you say that there is no evidence of effectiveness, but if these people are walking, functional people, isn't that some evidence in and of itself that they're working? So isn't it a matter of perspective?
Yeah.
You're the patient, not the patient?
Yeah, I would say that not everyone is walking functional.
No doubt, but
Right,
there's many
on
who
opiates.
are.
If there are many who are, then I think the conversation is about dose and concurrent benzos and just discussion of the risks. And then as they age and other things come up, you got to reassess and have that conversation about whether or not that's the best way to treat them. But yeah, the people that are functional and doing fine and back at work and are on a reasonable dose, there's probably a reason to keep some people on them. So think about tapering if they're not working, if the opiates aren't working, meaning that they're functionally not getting any benefit or they're having difficulty adhering to your requirements in the regimen. You can safely taper 10% a week. The lowest doses are going to be the hardest doses to wean off. I use clonidine a lot for those kind of final, to prevent withdrawal symptoms in those lower doses. Or even maybe you consider a referral for buprenorphine. Maybe someone needs a chronic low dose of some kind of opiate. If opiates are working but the patient wants to come off, well, that's a great conversation to have with people, and you can do it as slow as they want. And if addiction is strongly suspected, think about referring someone to comprehensive addiction evaluation and detoxing them with clonidine or buprenorphine if it's available, and stabilizing them. So responding to opiate use disorders. I'm a Coke person myself. Who becomes addicted? It's multifactorial, and one's genetics and personality traits contribute, as does one's environment, both about 50-50. So there are lots of influences on this. This is just the natural history of someone coming out of treatment, which just consisted of withholding the drug. 12 months later, so they compared alcohol, heroin, and nicotine. About 12 months later, only 20% remained clean and sober. Some people can do it. And this is with medication-assisted therapy for people on heroin or opiates. So people stay in treatment longer. 75% are substance-free after 1 year with therapy and medication. People on methadone and buprenorphine are less likely to overdose, have improved mortality, they have decreased illicit drug use, resulting in less IV drug use and subsequently less HIV and other infections mentioned earlier. They have fewer ED visits and hospitalizations and decreased criminal activity and better quality of life. And this was a comparison of 4 different studies that looked at various treatment lengths of people on buprenorphine, and across the board, people decreased other drug use, and they are more likely to be employed and have higher quality of life. And I'll say, prescribing buprenorphine is, it's really amazing the turnaround that people can make. It's actually, you know, you don't see diabetics turn around this quickly when you prescribe insulin. You know, this is really kind of a life-changing medication for these folks. As you know, in Vermont, we have the hub and spoke model. We're the only state currently that has a hub and spoke, but the hub, as you know, is the opiate treatment programs for the high-risk or unstable folks, and the spokes are office-based treatment, and buprenorphine and naltrexone or Vivitrol are probably being used the most and is appropriate for low-risk or stable patients. Just a word about medication-assisted therapy, buprenorphine or naltrexone. Buprenorphine is a mu receptor partial agonist, but it binds more tightly than other opiates. Has a very long half-life. People are usually on it daily or even every other day. It does not create any euphoric effects or respiratory depression that you get with opiates. And Suboxone is a combination of buprenorphine plus naltrexone, is all in the same tablet. And naltrexone is not active unless you were to crush or melt the film or the tablet. Then that activates the naltrexone. So if you're taking it sublingually like you're supposed to, you're just getting the buprenorphine, you're just getting the opiate effect. Gets a little tricky when people have painful procedures or surgeries or something and people are on buprenorphine. I've tried doing this all sorts of different ways. I've tried taking people off their buprenorphine and switching them to equivalent doses of opiates and then have them go through surgery and then try to convert them back to their Suboxone. It's actually, I think, a little bit harder to do that, and people have a little bit more trouble with that. Some people keep people on their same dose of buprenorphine and just give them a lot more opiate to kind of override that buprenorphine effect on the mu receptor. That also tends to sometimes get a little sticky because people get really nervous about giving people that much opiate. But that is a very effective way to do it. The thing I tend to do is I tend to decrease their dose of buprenorphine a little bit and then supplement with some additional opiate. They have surgery, they're going to need some opiate for some amount of time, and really try to put a window on that. Otherwise, I've seen people persist on opiates and Suboxone for months or years, or after surgery. But then tapering off the opiate and bumping the buprenorphine back up after surgery tends to be my preferred way to do it. And patients tend to have less trouble with converting from the buprenorphine to the opiate if you do it that way. But these folks do end up on very high doses of opiates around that time period where they need something for pain. Naltrexone is getting kind of a little more press. It's a mu receptor antagonist. It blocks the high from using an opiate. The monthly IM injections tend to be a little more desirable than the daily oral formulations. People can take a once-a-day pill. You have better compliance rates with that, the once monthly injection. You can also use that for alcohol, people with alcohol addictions. People do report reduction in cravings and a desire to continue treatment. The trick with that is that people have to be opiate-free for 7 to 10 days prior to starting it, which is sometimes quite hard for this population to do. Otherwise, you'll kick them right into withdrawal. Access to medication-assisted therapy around the state is here. The upper left is the number of people receiving medication-assisted therapy per 10,000 Vermonters. That number is gone up. And the lower right is the number of buprenorphine prescribers at UVM Medical Center. Most of this increase has been in family medicine. And we have gone from literally 5 prescribers to, I think we're up to almost 90 prescribers now, and APPs now can prescribe, which has been great. So we've had a big jump. initially, people were really resistant. You know, they didn't want those patients in our waiting rooms. So I'm like, well, they're already in your waiting rooms. You're just treating them for everything but their addictions. And then they said, okay, fine, we'll do it, but we'll only take 5, and they have to come out of my existing patient population. We're not going to take anybody new. And it took about a year, and it also took getting the addiction treatment program up and running. So the addiction treatment program, Centre at Maruti, they're kind of the bridge between the hubs and all the spokes. And so people decompensate, they can go back to the ATP for a bit, get restabilized, and then come back out to the spokes. And as people have been doing this it took about a year, that people were like, you know, this really isn't that big of a deal. I'm willing to take more than 5 patients and open my practice up to patients I don't know. Because as we know, there were lots of people that were stuck in the hubs with no primary care provider to bring them out to, even though they were stable. So that's been a huge shift over the past couple of years, which has been awesome to see. And the wait list has also declined. The Chittenden Center in Burlington has been saying that they currently don't have any wait list. That doesn't mean you can walk in today and get buprenorphine, but you can at least walk in and get your name down, and then they're about 2 weeks out now with starting new people walking in the door, which is fabulous. About 2 years ago, it was over a year, right? Which just puts people at risk for doing all the stuff they're doing. And the other thing that is also important to think about is that, you know, relapse rates or non-compliance, as we call it, you know, we call it relapse with substance use disorders, and we call it non-compliance with diabetes. It's all part of chronic disease management, and the relapse and non-compliance rates are really about the same for all these chronic diseases. So really trying to think about these patients as, you know, people with substance use disorders. It's a chronic disease. They're going to have relapses. They're going to have times of non-compliance. Stopping the Suboxone or kicking them out of your practice is not going to ultimately help them at all. But really what they need is just a little bit more kind of wraparound. So maybe more weekly visits, maybe doing bubble packs. I found that very effective. The pharmacies will pack them, you know, in their daily little bubbles. You can call them in for pill counts, and they should have everything right there in the little bubble pack where it belongs. Or if folks can go to the addiction treatment program, they can get them into group therapy and do a little bit tighter wrap around these folks. So what can harm reduction also look like? I talked about the chronic disease model to manage addiction. I think we've done a lot with efforts at destigmatization, that people using a drug or just that, a person using a drug. Less regulation around prescribing of buprenorphine. The buprenorphine prescribers in the room know it's not the easiest thing to get a license. You know, what about low barrier buprenorphine? What about, you know, someone that's actively using heroin? Can they walk in someplace today and instead of injecting heroin tonight, can I get a dose of bupe and go on my way? Something else to think about. Decriminalizing or decarceration of addiction-related crimes. Some of our judges in our communities and our state's attorneys have done a great job, but it's very different in different parts of the state. Some places they'll get, you know, funneled into treatment, and some places they still get thrown right into jail. What about people that are not interested in sobriety? What if they're not there yet? What if they're not ready to get clean? How can we reduce their risk of overdose and death? You know, there is some movement around the state to maybe think about doing safe injection sites. Is this some place where people can go to inject safely, as they do reduce overdose rates dramatically, and they increase people's access to treatment. Some more things to think about. These are some of my references. Dreamland is an interesting read, though. It gets a little repetitive. I don't think I actually finished it, but the whole timeline of how the whole thing kind of came about in the 90s when the heroin cells started coming over is really pretty fascinating. What questions do folks have? Yeah.
I'm on the acute team. A couple of things. It's a great review, thank you. There's also, for people my age, there's a very long article in the New Yorker, mostly focusing on Purdue Pharma, but discussing the same thing. I don't know who decided pain should be a fit vital sign, but that is a problem on our end because our staff, we treat patients in the hospital. They're cared for by nurses that are supposed to look at pain as a vital sign, and there is a perception amongst our patients that you're not supposed to have pain. And so, what's your score? And they look at a number, and then they're giving narcotics, and they may wake them up and they're giving narcotics. So, is there? First question is, how do we address it? Is that we're looking at our end and doing it, but how do we get CMS and all the people that do this to say, wait a minute, we have to. It's not a vital sign, it's a subjective thing. On the other end of it is, we do have patients who are on buprenorphine, and if we have a hub and two questions. A hub and spokes model. I can't tell you how many times I get different instructions from the providers I'm calling about how do we manage a patient who's in addiction treatment.
Yep.
Some, like you said, some say keep it going, some say stop it. And how do we get consistency in that for those of us on this end of it?
I don't have an answer for either one of those things. I would love to know how we do the whole pain assessment a little bit differently. Joint Commission was at UVM last April, and we had a couple findings around pain assessments and reassessment of pain, so it's still kind of on their radar. Joint Commission would tell you that you don't have to use opiates to treat pain, that we're just telling you you have to assess and treat pain, but we're not telling you what to treat pain with. Yeah, it's still a huge focus though around pain. And we also run into the same problem with buprenorphine folks, clients, and having painful procedures, and we do not have a consistent way on how to manage that at UVM either. So, yeah, I don't have an answer for you on that. There's not necessarily one way to do it, but
it's the number one Press Ganey question too. First
What's
thing
your
they ask was my
control?
painful managed in the hospital and
yeah,
after.
yeah,
And you think if it wasn't.
right.
Patty, have you all talked about how to address the conversation around pain acceptance? You've got some great faculty up there that deal with motivational interviewing. Have you all talked about how to structure that conversation? Or do you even believe in that approach?
Yeah, I don't know. That's a good question too. There's been a lot of people that have gotten trained with the motivational interviewing, and I guess I haven't done the training. It'd be interesting to know from some of them that do it, if they are using it in their practices, and if they're using that to try to shift patients' perception of their pain. I don't hear a lot of talk about it, honestly. It seems like it would be a huge benefit if we could broadcast that more widely and even use it on the inpatient setting. Yeah, have a good thought.
I understand some of the earlier slides correctly, that it seemed like as there was a greater tightening then of the availability of opioids, that people are just replacing these then with alcohol and heroin. And
Yep.
I'm not sure how that's advantageous. And it's certainly not one for one, I imagine, but.
No, with fentanyl and tramadol, with the synthetic opioids now, it seems like it's increasing even more dramatically than the heroin did, when the opiate supply decreased. So no, we haven't put a dent in this epidemic at all by all the things that we've done to shift our prescribing practices, the abuse deterrent formulations, the prescription monitoring systems. None of it's created a dent.
Are there fewer people becoming addicted? Have we seen a drop in that? Are we seeing, the slide you're showing, are those showing people who unfortunately we've helped create an addiction? Those patients are now addicted and switching to other drugs because the prescriptions are not available, or are there just new people becoming addicted?
I think there's still new people becoming addicted.
Same rate, or is it increasing?
I think it's increasing.
I think the supply through trafficking has skyrocketed. It's just flooding the market.
The supply of heroin has skyrocketed for sure, and fentanyl.
So do you have any sense, of, I have a hard time wrapping my head around, we have these, I think I would agree with you, great treatment program, or almost great. I've been prescribing Suboxone for several years, and I share the same sentiments. It's a pretty amazing way it can turn some of these folks' lives around. And so why are these people still using heroin or whatever else they're using? It doesn't sound like it's that hard to get into the system nowadays, and and lots of us are prescribing Suboxone, so
Yeah.
I just can't understand why people
I
aren't,
don't think
more
there's
people aren't
still
taking
enough
advantage of it.
availability. There are a lot of private docs who won't prescribe buprenorphine still, and I think some of it's because of Medicaid reimbursement. I think the docs that are associated with some of the hospitals and the systems that aren't